Hi, everyone, and welcome to the concurrent ASCO commentary on the review of role of secondary cytoreduction in recurrent ovarian cancer. So, this is a nice opportunity to kind of do a postscript on the review. In my discussion, I spent a fair amount of time trying to tease out how GOG-213, obviously the trial that we've performed within the GOG and now published, fits into the context of these two really important surgical trials, which in and of themselves are extremely difficult to do, as you can imagine. So some questions that came back to me, and I think I'll try to address them here, are listed here. The first is both of these abstracts on the impact of secondary cytoreduction surgery in recurrent ovarian cancer are based on international studies, or there are U.S. trials that reflect similar findings. So as I outlined and just mentioned, GOG-213 was an important trial that was launched several years ago. Actually, in the current form that most of you are familiar with, it was actually launched in 2007. And that was actually a reboot on a trial that was called GOG-202, which was actually launched in the year 2003, just for very briefly. And it was predominantly a multi-arm chemotherapy question addressing whether or not sequential treatment was as good as combination treatment. But there was a surgical arm attached to that trial as well. So this trial, GOG-213, was launched to address two primary endpoints. So it's very important to know that this is not a bifactorial trial. It actually has two kind of studies within the one. And if you collect all of the patients that were enrolled in GOG-213, it would be almost 1,000 patients. The first objective was really to address the role of bevacizumab added to paclitaxel and carboplatin for patients with platinum-sensitive recurrent disease. And in that subgroup of patients, there was also the opportunity for the same patient to participate in the surgical question, which was not led by any specific guidelines as to how patients should be selected, other than the fact that they should be only those patients for whom a complete gross resection could be achieved. So while this trial was ongoing, addressing the chemotherapy question, Desktop 3 started, as did subsequently SOC1, and both of those trials are here at ASCO. So GOG-213's chemotherapy question was completed. It demonstrated a significant impact of bevacizumab added to chemotherapy, which importantly now it becomes very relevant in how to interpret the results of GOG-213 in the context of these other two trials. And so if you look at my review or watch my review, you'll see how I think that has impacted the trial's outcome. So the second primary objective was to look at the chemotherapy question. So once the chemotherapy question was, the surgical question, once the chemotherapy question was completed, we allowed the investigators to use the chemotherapy of their choice once they randomized patients to surgery versus no surgery. At the time of that trial, the chemotherapy question closed, we had enrolled about 107 patients onto the surgical arm of that trial. And so the remaining, over 480 patients, 380 patients were added subsequently to complete the trial. And so as we published last November in the New England Journal of Medicine, demonstrated that there was no benefit to surgery in patients who were felt to have a complete amenable for surgical cytoreduction. And of the two trials that we've just reviewed, SOC1 and Desktop 3, the Desktop 3 trial demonstrated that there was a benefit to overall survival in patients who had a complete gross resection. And the SOC1, although the overall survival wasn't completely mature, the curves are essentially overlapping, and they concluded that there was no benefit to overall survival, at least at this point. So basically we have two trials that essentially are negative, one trial that's positive. And so it'll be very important to kind of go through the nuances of those trials. But one of the glaring differences between these trials are two. One of these is that SOC1 and Desktop 3 both use the triage algorithm to identify the patients. And that resulted in a complete gross resection rate of between 74 and 76%, so around 3/4 of the patients. In GOG-213, the complete gross resection rate based on just the investigator opinion was about 67%, so about 2/3 of patients. If you do the math, there's really no statistical significant difference in those frequencies, but it's definitely something that's highlighted by the surgical trials, in that it seems as that only the patients that benefited significantly were those that actually had a complete gross resection. It's almost to the point where if you attempted a surgical procedure and did not get a complete gross resection, it was actually harmful to patients. In other words, patients who got chemotherapy but did not, fared better than those that actually had a surgical attempt that failed and then went on to chemotherapy. And so it raises the question, it's like, well, if chemotherapy is so good, why didn't it rescue those patients who had a poor surgical outcome? And again, that's a really valid question, and I don't know. But one of the things that's clear, if you compare across these three trials, is that the control arm in GOG-213 is the real outlier. This is the group of patients that were felt to be good surgical candidates but got chemotherapy. And in the United States, 85% of those patients also received bevacizumab, which, as I mentioned, in many of the trials that have looked at bevacizumab, but particularly in GOG-213, when it was added to paclitaxel and carboplatin, we actually saw an improvement in overall survival. So maybe that's the key difference between these trials. I don't know. And it'll be very difficult for us to completely sort out. However, the good news is that each of these trials uses a similar type of design for patient eligibility, meaning that we looked at patients with only one prior regimen, patients that had to have a platinum-free interval of at least a year, at least 6 months, and many of them were quite platinum sensitive based on the median platinum-free interval. So I think in the context of these, we'll have to go back and relook. I think one of the major deficiencies of all three trials is the lack of BRCA information, and that, in the context of the current treatment environment with PARP inhibitors also being on the scene and showing the dramatic effects they've had in patients, again, who have not had surgery, we'll need to continue to evaluate what the critical role of surgery is in this patient population. Second question is, how might COVID-19 pandemic impact the ability of gynecologic oncologists, regardless of their location, to schedule these secondary surgeries? Well, again, if you feel like that secondary surgery is important, as the pandemic is addressed, it really gets down to the individual hospitals as to how and where and when these can be scheduled. As you know, most hospitals are now bracing for the impact of a onslaught of patients who are COVID-19 or coronavirus exposed, and for those that develop COVID-19, the need for ICU. So there's been a bit of a throttling on the amount of surgery that's being allowed, and in this case, potentially elective surgery that's allowed. So these will essentially be prioritized depending on how the individual hospital is affected by the COVID-19 crisis. Since there's dispute as to whether or not there's an absolute critical role for surgery in this setting, I don't feel like there is a huge impact to patient outcomes with respect to this. But obviously, depending on how you view these trials and their collective, you feel about that, that will essentially affect the way that you would prioritize the need for this particular intervention in patients with recurrent ovarian cancer. And then the last question is, what else would you like to say about these abstracts, specifically to for your SGO colleagues? Well, what I would say, first of all, thank you for supporting the trials and for enduring through these really critical times that are so unusual. It's so odd to not be able to connect with people in person. And so I would say, be strong, be safe. But I would like to just, close by, having people think critically about these trials. Remember that primary endpoints are extremely important in interpreting clinical trials because they are set to hypothesis addressing testing standards, which means that there's appropriate alpha allocated for the question. So as you remember, in GOG-213 and Desktop 3, progression-free survival was not a primary endpoint. So although you'll see p-values, like it was addressed as a hypothesis, they are truly just hypothesis generating. SOC1 actually has a co-primary endpoint, so there is alpha allocated to PFS, and that's why if you look at their report, you'll see that the PFS question was met, and so the alpha was passed to the overall survival, where it basically stopped because it couldn't pass that particular analysis. But remember that these are hypothesis-generating experiments, such as the complete gross resection rate versus non-complete gross resection, or complete gross resection versus chemotherapy. All of these, interesting curves that we are doing, including these indirect cross-trial comparisons, which actually may apply to a situation like this, where the eligibility criteria are essentially the same for all of these trials. They still just generate more hypothesis, and it could lead to a potential another attempt at trying to address the nuances of these questions. But again, I would like to say, please take a look at these, address them critically, and hopefully they'll be informative in making decisions at the patient level. So again, thanks so much for tuning in. And if there are questions, go ahead and send them on to the SGO, and we'll be happy to try to address them. Have a great day.